Okay, well, thank you for being here with us today, all amateurs that are listening and monitoring here, as well as those that are watching us on YouTube or on Zoom. We're celebrating Thanksgiving in a healthcare hymns sort of way, and medical advances we're thankful for, as we mentioned. It's a sort of continuation of a series of Thanksgiving related topics. We do, and our nets do timely discussions at times of the years. Veterans Day, for example, Memorial Day. We'll pick up subjects of medical relation to those, and some of them are very engaging. We do have a YouTube channel, and you'll find some of those on the video on the YouTube channel. So just look for youtube.com and look for the Healthcare Hams channel. So if you just go to youtube.com, go to search Healthcare Hams, you find the channel. I think you'll find these very engaging. So the ones we've already had here that are Thanksgiving related, and this is really our fourth discussion about Thanksgiving and human health. And the first three are on YouTube, available on that channel. But we talked about pumpkin and nutrition to start off the holiday season with Thanksgiving. And we continued with salmonellosis, so we could discuss how to properly prepare turkeys and other sources why individuals might get sick from poultry and other animals and with that bacterial infection. And also last week we talked about tryptophan in turkey, a sleepy connection. In the last 2 weeks we had that discussion, whether or not there is a direct connection. And we hope that you'll view those. I think you'll find them engaging in a kind of folksy way that we do here today. I'm not going to go into detail about those because you have them direct to use on the internet. And today we're focusing, of course, on gratitude and thankfulness. And we've discussed this topic before in different contexts, but being grateful is a deep internalized feeling of thankfulness. And we're expressing thankfulness to those who have made contributions toward the advances who have benefited their health. And of course, we have many of our own members that have made those advances. Everyone contributes in their own way. And our roundtable discussion on weekly Grand Rounds in the Air is a shortwave radio 20-meter net. And I'm the host of the session today, but expressing our thankfulness as individuals, once again, not the opinions of the organization, but we look forward to active roundtable discussion. We'd like to hear everybody's point of view. Everybody sees the world through a different set of eyes, through a different set of experiences, and everyone's opinions and input is highly valued. The Medical Amateur Radio Council as an organization has been in existence since 1966. We are an ARL affiliated club, but our net and our organization are not limited to those that are healthcare professionals. So I want everyone to feel they have the opportunity to contribute. If you're not a member, still we'd like you at the breaks for check-in to check in. In one of our recent programs, we did talk about gratitude and well-being, and we linked an article, and we talked about a particular article that was by Sansone and Sansone on gratitude and well-being, the benefits of appreciation. You can just Google that. Sansone is the name of the authors. It's in the Psychiatry Journal from 2010. With that information, you should be able to find that and see the relationship between gratitude and well-being. So it's important as part of this Thanksgiving season to not forget the reason for the season. It's not just for the food that we're going to partake in, it's to show our appreciation. And I'm sure every family does a little bit differently. Hopefully you do pause and show your appreciation in general. Now, I'm going to start by saying what I'm most thankful for here in recent years. And I don't think it's necessarily controversial, but it's an ongoing appreciation. We're finding out new information all the time. For me, it's the mRNA vaccines, the messenger RNA vaccines, the ones developed to use a copy of a molecule, messenger RNA, because we can produce an immune response and rapidly make these vaccines in response to a new disease. So they were already ready to go here when COVID-19 came out, and I was able to speed up the response and bring a product to the, albeit, a fairly new technology. And that's why I said it's still ongoing. There's some skepticism by individuals in society, and we can understand what we're not familiar with. And unfortunately, we had to rush to use that. And we had such a challenge here. I mean, we were dealing with a pandemic, a serious pandemic where we were having in the United States 1.1 million deaths over the first 2 years. So once these vaccines are developed, they deliver molecules of an antigen-encoded mRNA into cells, which use a designated mRNA as a blueprint to build foreign proteins. Now, they would normally be produced by a pathogen, such as a virus or a cancer cell, but being part of the vaccines, these protein molecules stimulate an adaptive immune response that teaches the body to identify and destroy the corresponding pathogen or cell cells. So during COVID-19, our nets were extremely active. We had a lot of interest across the board to what was being reviewed in our publications in our nets. There was a large focus even on our digital nets. And we can understand the challenges to society at that time, why individuals were so engaged. The mRNA is delivered by a co-formulation of an RNA encapsulated in lipid nanoparticles that protect the RNA strands and help their absorption into cells. And we were in real time talking about all these challenges, not just here in the United States during that time on our net, but also internationally. We are an international organization. For example, we have a member in India who's a biostatistician with the Indian Army. We were hearing in real time what was going on in India about COVID, as well as hearing also in Japan and Brazil and other countries. So there was a lot of interesting conversation going back and forth. Countries were developing these new vaccines and having them available at different times. But with this lower cost of production, make sure to I'm sorry, okay. They facilitated the design of the new vaccines with the speed and lower cost of the production, gave you induction of immunity at both the cellular level and also the humoral level. So you have the cellular level where you're activating your phagocytes, the antigen sensitized cytotoxic T cells, and having a release of cytokines and chemokines in response to the antigen, where the humoral immunity was antibodies that are produced by at the B cell level. So you get both of those happening on. And it has to be carefully done without interaction with genomic DNA. So in popular culture, and I'm sure this was one of the concerns with the new technology, you had, for example, the Planet of the Apes movies, where you had a modification of genomic DNA and the humanity was challenged by that. So it's part of our culture at this point. And the source for this is Wikipedia, this particular information. So all the different, if you go to the Wikipedia page for mRNA vaccines, you'll see all the different links behind it, all the basis for what they say here. I'm going to pause one here, and we're going to go ahead and do any additional check-ins here at this time. Make your call to Whiskey Bravo 5 Delta. Yeah, I've got Whiskey Juliet 8 Bravo checked in here from online. Any further check-ins, make your call to Whiskey Bravo 5 Delta or use NetLogger. Go ahead. Is there another check-in? Make your call. Okay, no additional. We'll pause again. For ID purposes, for those of you that are listening, this is Whiskey Bravo 5 Delta, the Medical Amateur Radio Council, the grand rounds of their net. We meet every week at this time. We are thankful. We're thankful for advances in medicine. We're also thankful for the amateurs that allow us the use of this clear frequency. If you go to a website for the NIH, you look for the Gratitude Biomedical Progress for all those who make it possible, looking for a blog post from the NIH director in 2022. He showed the appreciation for the mRNA vaccines, and he's crediting it with enabling the widespread availability of COVID-19 bivalent booster shots. Now, the boosters not only guard against older strains of the coronavirus, but also broaden immunity. And at that time, it was the newer Omicron variant and its many subvariants. And of course, as vaccines mature and they're updated, it's continuing on with new varieties, new subvariants. So he was tremendously grateful, everyone who has or soon will get boosted to protect yourself. And we'll talk a little bit about herd immunity and why it was so important to get the vaccines. Of course, many of our members know that already. We've been having this discussion for 3 or 4 years. But for your loved ones in your communities, it tends to be a little bit more in the winter months, and that's approaching now. We'll have to see if any new subvariants come out. And he gave a big thank you to the researchers themselves that were studying not only COVID-19, but long COVID. And I know many of our members have had long COVID. It's such a serious issue that's complex and potentially debilitating. It's a constellation of symptoms that strike some people after recovering from COVID-19 and linger. We've had members that have had issues for years. I've had friends that are in the medical profession that are still having issues years later. So it's important that the research go on, and we appreciate all that those that work hard to find answers to this work as it continues, because they certainly cannot do it without our patients and our members of society contributing and being supportive. So he shows an appreciation. This is again the NIH director for the NIH Institute. The center directors contributed to their blog to showcase the broad and diverse portfolio of promising research. And we spent a lot of time on COVID-19, and today we'll just talk about it in the context of herd immunity. So as we talked about the reason for getting vaccinated, if we did not, we just waited for herd immunity to happen through natural disease progression from individual to individual. We had 1.1 million deaths just here in the United States in those 2 years. And how do we know that? People that are sick, they have other issues, they're dying. How do we know that it's COVID-19? Do we know that directly? Well, let's look at COVID-19 in a vacuum in just a minute. If you didn't have COVID-19, how many people normally die? Well, then you look at how many people did die, and you see there's excess deaths. So whether it caused it directly or exacerbated existing conditions is irrelevant. Those are deaths that would have not occurred had it not been another stressor. And we talk about stressors all the time in our organization and our meetings. We talked about it recently with daylight savings time. There being a small increase in myocardial infarcts, maybe it's 3% in the spring in some communities. And it's just an additional stressor. The time change didn't cause the heart attacks, but the overall burden on the individual, that might have been what tipped the scale. So as we talk about the herd immunity, the vaccine was very valuable in making sure that the individuals in society are protected. If you have enough people that are vaccinated or have had the disease, then you won't have new expressions of the disease. I see now we have N3PQ checked in with us. Munir's here with us today, and he's going to be doing some contributions. We have slides that are sourced in our background material here that we're presenting on the air, and we'll be giving Munir some microphone time to talk about his experience and what he's thankful for. But you can look for COVID deaths. I mean, we did say, obviously, we were looking at the excess deaths, and that we know they didn't exist until the disease was present. But it wasn't necessarily uniform. I mean, if you look at different, and there's research here that's available online, the leading causes of death in the US during the COVID-19 pandemic from March of 2020 to October 2021. And if you look for that article and you search for it, you'll see charts that look at different age groups. And you'll see the relationship between COVID-19 deaths and other deaths and how it's changed over time. And the age groups, the percentage-wise, had the most impact were the ones that were 45 to 54. I know a lot of individuals that were elderly passed away of it, but they were still passing away primarily of other diseases as well. That didn't change. And they had more individuals because of their age that would pass away from natural causes than COVID-19. But you wouldn't expect someone that would be 45 to 54 to have that same scenario, because they're chronic diseases or haven't really progressed to that point where a stressor would make as big of a difference. And COVID-19 itself started to become the prominent cause of death in that age group. You can look for that article yourself. Just Google that, and I think you'll find that to be interesting. And the COVID excess deaths in the United States, we're talking about 656,000 extra deaths in 2020. The second year of the pandemic, we're talking about 587,000 excess deaths. So I'm doing the math here, but that's over 1,100,000. And the excess deaths increased from the first year to the second for persons younger than 65 and low vaccination states, particularly. So again, vaccination made a big difference. We also started to get herd immunity because of the vaccination, or individuals getting the disease, which accomplishes the same goal. Starts to give you partial immunity, at least immunity for a certain amount of time. So at this point, let's go ahead and pause for identification. Whiskey Bravo 5 Delta, the Medical Amateur Radio Council, Grand Rounds of the Net. We have N3PQ checked in. Do we have any other check-ins at this time? Make your call, Whiskey Bravo 5 Delta. Oh, it's great to have you here with us today, W4EMD. I've got you checked in. Any additional check-ins? WB1FFI, Barry from New York. Would you like to ask for any additional check-ins that might be hearing you? Go ahead. Okay, no additional check-ins. We'll pause again a little later in our roundtable discussion, as well as we'll be taking lists for individuals to make presentations. But before we get into the details of what we're most thankful for, and we'll start with some that have sent their comments in at a time. Are there any questions or comments from the general group? Please make your call to Whiskey Bravo 5 Delta. Well, Munir's here with us, N3PQ, and I know you're thankful for monoclonal antibodies. And Munir, let's get a signal check from you on the air. Go ahead and call Whiskey Bravo 5 Delta.
I'm on the Zoom call only.
Okay, I've got you fine on the Zoom call, Munir. Okay. So yeah, I'm going to let you go ahead and take the microphone. This is N3PQ with Whiskey Bravo 5 Delta.
Okay, thank you so much, Jay, and thank you, everyone. I'm actually in my car on the Zoom call, but my wife is driving, not me, so we're okay. I can remember not too long ago, in the 1980s, 1990s, and even early 2000s, when we had really very, very little we could offer patients with multiple sclerosis. We could offer them all kind of steroid medications. There was a famous one called Acthar, ACTH, Solumedrol, and not much else. As a matter of fact, we could treat any attack. You know, multiple sclerosis is an autoimmune disease, mainly attacking the myelin sheath of the nerves, the protective and conductive. It's like an insulation, but at the same time, it helps make the conduction faster in the nerve. And it attacks that mainly, but eventually it also attacks the axons, the actual nerve and the nerve structure and the neurons, and can even cause some neurodegeneration. And then it was the luck of the draw. Some people had several attacks and recovered. Some people never recovered. Some people eventually became wheelchair bound. My uncle's wife had that at a young age, and she actually died fairly young at 58. There was not much we could offer her at the time. This was a long time ago. And then we had some newer medications. We had things called interferons, and we had Copaxone, and a few other medications that did make a difference. And I remember attending a lecture decades ago, and somebody saying, keep an eye on monoclonal antibodies. They are going to be the future of medicine, of neurology. And at that time, it was difficult to imagine, but they really turned everything upside down in medicine and neurology, especially for multiple sclerosis. And even now, the new medications for Alzheimer's that we keep hearing about, they are monoclonal antibodies. So for multiple sclerosis, we went from being able to offer treatment for the acute attacks to actually being able to give patients with multiple sclerosis a normal or almost normal life, a normal lifespan. There are some patients that do not respond to treatment, but the vast majority of the ones I've seen respond very well. We have medications, I'm going to name some generic names, natalizumab, ocrelizumab, ofatumumab, and many other similar medications. And you can tell it's a monoclonal antibody by how it ends, by MAB, M-A-B. That's the giveaway, of course. And the trick is not to wait until the MS becomes severe. You know, sometimes there's a tendency to say, oh, you know, the patient is still very mild. They might not need anything strong. We'll start with the weaker medications first, with the interferons or with Copaxone or something like that. That thinking has rapidly changed. And the idea now is to hit early and to hit hard at the MS. These new medications, the MABs, are not without side effects like infections, including brain infections. But all in all, the side effects are manageable and preventable in some cases. So we've seen it's no longer. One of my patients said that she is on the path to a wheelchair. This was decades ago. Nowadays, there's no reason for that anymore, really, except in some unusual cases. Cases of MS, most patients with MS have what's called relapsing remitting course. They get worse, they get better. Some have primary progressive MS that is more challenging to treat, but with the new medications, it's getting better and better. And these medications work so well. I don't wanna like over exaggerate. I don't want to exaggerate how well they work, but they work so well that it almost made me forget the old days when we had nothing to give. I remember we used to some patients out of desperation would go and get bee stings and pumpkin seeds, and you know, I don't name them, try anything. But now it's really a totally different era, and I'm very, very, very thankful we can offer that. The reason I'm in my car, I was attending a conference yesterday in Hershey, Pennsylvania. It's a neurology conference, and two of the main topics were multiple sclerosis and Alzheimer's disease. So the other field where we're not there yet, but you've heard of medications such as Leqembi and other aducanumab and lecanemab. They are being used now to treat the symptoms of Alzheimer's disease. So they, what they do, as you might know, in Alzheimer's we have accumulation of amyloid plaque in the brain and something else called neurofibrillary tangles. Some of it is genetic, some is not genetic. It's a complex picture. But these new medications are starting to make a difference, not as dramatic as with multiple sclerosis, but quite a difference. And they actually clear the amyloid plaque from the brain. Donanemab actually clears it quite fast, and lecanemab more slowly. So like I said, Alzheimer's, some of it is familial, and it depends on something called the APOE epsilon gene. And if you have the epsilon and the ApoE2, you're in good shape. That's actually supposed to be kind of protective, if you want to call it that. If you have the ApoE3, that's neutral, doesn't increase your risk or decrease your risk. But if you have the ApoE or ApoE4, that increases your risk of Alzheimer's disease. So the idea is we now have some serum biomarkers. You can do some blood tests, not only for that, but to see if you have tau protein and if you have amyloid. And the idea is hopefully eventually we can start it at a very, very, very early stage where somebody is either not cognitively impaired yet or just at the very beginning of cognitive impairment. So I think it's a good time to be living in with regards to medicine and specifically neurology. These MABs are also used to treat cancer, sometimes very effectively, but I cannot address that part. I'm not really knowledgeable about that much, except I know they work very well for some cancers. That's what I have to say, Jay. I don't know if there are any questions.
Yeah, this is Whiskey Bravo 5 Delta for ID with November 3 Papa Quebec neurologist Munir here at the microphone. Hello, Munir. Thank you for Munir. We'll have plenty of questions. Yeah, I had a comment or question myself, and as you were describing, I think you answered it in part. So we're dealing, and we'll talk a little bit more about monoclonal antibodies and what they are, where they're made, and how they're delivered. But the question was, for me, that I was going to ask you was, is it personalized medicine? Or is it just designed to bind to, say, certain receptors or get a certain response that might be different in individuals? And what you described to me was with the serum biomarkers and looking at the genome of the individual, I guess that is personalized medicine because it's semi-personalized at least, because they know by the expressions of your genes and the biomarkers whether or not the medication would be effective or useful for you. Because without that specificity, I think we would just be hitting everyone unnecessarily with medication that would not help them, and in a way that the ratio of benefit that could actually be harmful or put them at risk unnecessarily so. So before I ask for questions from the general group here, would you like to comment on how you think that the future of personalized medicine, monoclonal antibody production may proceed? N3PQ, Whiskey Bravo 5 Delta. Go ahead, Munir.
Yes, this is N3PQ. Yes, Jay. So we are heading in that direction. It's not, like you said, it's maybe semi-personalized when it comes to Alzheimer's. Not so much for multiple sclerosis yet. But the thing is that many of the MABs really work so extremely well that regardless of the genetics, they seem to work quite well. I think eventually, you're right, we might find that some people might respond better to certain MABs than to others. But right now, they seem to be all quite effective. When it comes to Alzheimer's, yeah, the idea behind the personalized medicine part of it is that if you can identify, let's say somebody whose father or mother or both had Alzheimer's dementia, then yeah, they would be tested early on if they wish. And if they show risk factors in their serum biomarkers, again, they're not 100% specific or sensitive as well, but again, we're heading that way. Then yes, if it were me, for example, even before I got significant memory symptoms, I would want to take something. Now, the other way this is heading, the very first medication that was the very first medication of this class that came out for Alzheimer's a year or two ago was very disappointing. Aducanumab. First, the FDA didn't approve it, then they approved it, then there were questions. And the truth is, it wasn't a good medicine. But at least they were trying to open the door there, and they opened the door to the new developments. So the two new ones are the ones I mentioned, donanemab and lecanemab. But I think we're just starting. Every they come up with a new medicine and they find the side effects, then they fine tune their formula, so to speak, and they come up with better medicines. They use more humanized molecules, human-like molecules. So yes, it's going towards that, and it's not beyond imagination. I mean, 30 years ago it would have been, but it's not beyond imagination now that one of these days we're going to treat Alzheimer's disease as effectively as maybe we treat blood pressure or diabetes. So I think that's good. This is N3PQ.
Okay, thank you, Munir. N3PQ, Whiskey Bravo 5 Delta. We'll be pausing here just for a minute in a moment for additional check-ins, also questions from Munir. You know, Munir, it's interesting, you mentioned opening that door, and we had talked about COVID before, the mRNA viruses, vaccines. And having, I believe from memory, they had done a lot of research for Ebola with those vaccines, and they weren't necessarily as effective at first, but it did speed up the ability to adapt to new challenges. So I think the point I was trying to make before, the question I was trying to ask about personalized medicine, and I didn't mean that it was going to harm anyone, but if you think about the therapeutic index and how susceptible children are, because that therapeutic index may have a smaller safety zone on somebody of a low weight, that you definitely want to be able to check it out and personalize therapies to reduce the risk to children. So even more pronounced there. So I at this point, this is Whiskey Bravo 5 Delta, Medical Amateur Radio Council, Grand Rounds of the Air Net. This is a roundtable discussion. This is not a lecture or not a presentation. This is a net, after all, for individuals that have passions with amateur radio and medical related topics. And I'm sure you have questions from Munir, and we'll talk more about monoclonal antibodies and cancer in just a moment. But Munir being a neurologist, and you might have questions for him in that vein about MS and anything else that he mentioned. I'll take a list here for those that have questions. Make your call to Whiskey Bravo 5 Delta.
KE5BQK checking in.
Okay, we have KE5BQK checking in, and actually, Linda, I'm so glad you're checked in, because you're next up on our discussion as we talk about cancers and monoclonal antibodies. Any questions or comments now related to Munir's before we move on to general discussion into Linda's point of discussion? Make your call to Whiskey Bravo 5 Delta.
It's WJ8B.
Okay, WJ8B for discussion. Any others? Go ahead. Okay, Andy, WJ8B, why don't you go ahead and take the microphone? This is Whiskey Bravo 5 Delta.
Okay, well, this is a question from you. He's talked about very important things. And one of the diseases I know that they do use monoclonal antibodies, it's in neurology, would be myasthenia gravis. And I just wondered if you would have any comments about that disease entity and the use of the antibodies.
Yes, absolutely. This is N3PQ. Absolutely. That's the other place they're using it now, is in myasthenia gravis. I haven't used it myself so far. By the time I was close to retirement, these medications became available, but it was extremely hard for a small office to get them approved. But what I did do is I would send them for myasthenia. For the others, it wasn't hard. So what I would do for the myasthenia patients is send them to the university center nearby in Pittsburgh, and they would get them approved. And absolutely, they are also fantastic for myasthenia gravis. another paradigm shift in medicine, if you will. This is N3PQ.
Thank you.
Okay, thank you for that line of questioning, Andy.
Right.
WJB. Do we
I do
have?
want to.
Go ahead, Munir.
I'm sorry, I didn't. I do want to say something. When it comes to multiple sclerosis, the insurance companies and the drug companies were very, very, very helpful and cooperative. You know, typically we have to jump through hoops to get medications approved for certain conditions. But when it came to, I'll give you an example for multiple sclerosis without naming any specific companies. The pharmaceuticals would provide medication for free until the insurance was approved. They didn't ask any questions. Here's the medication, take it. If it's approved, it's approved. If not, we'll figure something out and you have to pay out of pocket. So they really behaved in a very ethical manner in part. And I'm definitely grateful for that. This is N3PQ.
Well, thank you for those additional comments, Munir. N3PQ. This is Whiskey Bravo 5 Delta for ID, the Medical Amateur Radio Council Grand Rounds of the Internet that takes place every week at this time. We appreciate all amateurs, and we're thankful for the amateurs that allow us the clear frequency for the net. We hope that you find it of value. All individuals in amateur radio should be interested in their health as well. We have a tendency to sit at the microphone a little bit more than we should. We need to get out and take care of our bodies. But here we're taking care of our minds at the same time we're enjoying our hobby. Now, we did not really go into the details about monoclonal antibodies and what they are and how they're produced. And we'll talk about that in a moment. But we do have Linda here with us, KE5BQK. And Linda, I know you're on the road yourself, I believe. I don't know if you've gotten home yet. I'm going to let you go ahead and talk a little bit about what you had emailed me. I do have information available on the Zoom side for your comments. But please go ahead and take the mic. KE5BQK. This is Whiskey Bravo 5 Delta.
Well, good morning, Jay. Thank you. We're just about to leave to go to Ruidoso to the monthly blues jam, where I'll be playing the blues harp. But I just wanted to take the opportunity to mention that the drug Herceptin was in clinical trials when I was working as a clinical research nurse for Texas Oncology, and we participated in those trials. And then in 2016, unfortunately, I was diagnosed with breast cancer, and I was both ER, PR, and HER2 positive. So I was grateful to have Herceptin, trastuzumab, as a drug that was available to me. And I also got Perjeta, however you pronounce that one, pertuzumab, which was invented a little bit later than the trastuzumab, but I received that drug for almost a year. I had started having a few side effects, some infusion reactions toward the end, so I cut it a little bit short. I think I missed one dose short of a year's worth. But that drug is just a miracle drug, and it saves so many women's lives. And there is a wonderful movie called Living Proof. You'll see that if you're on Zoom. Jay has put that picture of the movie up there for you, and I highly encourage anybody to look at it, to watch it if you haven't seen it. It's just it was just a really heart-wrenching movie about how so many women died and the difficulties in getting this drug on the market. Thanks to this Dr. Dennis Salomon, he persisted in his research and finally convinced Genentech to do the clinical trials on it, and which led to its approval. So it's just a wonderful thing that I was able to get the benefit of, and it's probably saved my life. And that's really all that I wanted to say about it. But I'm just grateful and thankful for that drug. Go ahead, Jay. KE5BQK.
KE5BQK, Whiskey Bravo 5 Delta. By the way, my home call is Alpha Alpha 4 Foxtrot Lima. And my name is Jay. And we're broadcasting, we're transmitting. We're amateur radio operators. We don't broadcast. We're transmitting out of Hawthorne, Florida at my home QTH, Whiskey Bravo 5 Delta operations. So, Linda, what you just said had a tone of similarity as we were having the discussion with N3PK, PQ, excuse me, that you had mentioned the different biomarkers that afforded the specificity that you would be receptive to that particular drug. So as we talk about personalized medicine, I guess that's the first step forward until we can do it all at the gene level. Are there any comments that maybe those that are more wise about that subject than I am? We'd love to take a list and hear from you all. We'll make a list now. Make your call to Whiskey Bravo 5 Delta. Oh my gosh, we have so many Renaissance men and women on our group. I feel honored that you're having me lead the discussion here. The Living Proof movie that Linda talked about was on Lifetime television film. You might be able to YouTube and see if you can find that. I don't know if Lifetime has an archive available, but I think you'll find that very interesting, as Linda mentioned. We do have some information on the drugs that we'll talk about in a little bit, Linda, but we did want to talk about monoclonal antibodies in a little more detail themselves here. So, what are they? I mean, they're a type of biotechnology, and it's revolutionized the treatment of some diseases that we just talked about. They offer a more targeted and effective approach than some other therapies. I mean, that's what we're talking about, the specificity, and here knowing the types of individuals that can respond to a particular therapy. And you can find this information if you go ahead and look at cancer.gov, and what you should be Googling is about cancer treatment, types of immunotherapy, monoclonal antibodies. And you'll have direct access, anybody here that's listening on 20 meters, to that information. You'll find many slides and information from cancer.gov about this subject material. They explain monoclonal antibodies. They're artificial, so they're antibodies that are produced in a lab from a single type of immune cell. Those cells can then recognize and bind to specific molecules, or the antigens, as we all know, on the surface of cells or pathogens. So we're looking at particular biomarkers and particular antigens that people are susceptible to bond to expand upon that conversation. We haven't gotten to the point yet where we do, but it's probably still being improved to actually do specific treatments for you as an individual rather than just relying on biomarkers. So with AI and with quantum computing, think about all the crunching they can do of information. And if they can get a look at your genome and know everybody else's genome, that the treatments were effective for, eventually all that's only going to improve with time. But the antibodies are made in the laboratory. The monoclonal antibodies are engineered cells for those specific antibodies. They can be derived from human, animal, and hybrid sources. And as Monera N3PQ pointed out, we're getting a lot more improvement from doing it from human sources. Yet we're looking at immunoglobulin. Some monoclonal antibodies are used to treat cancers, such as leukemia, lymphoma, breast cancer, as Linda just spoke about. They can help kill the cancer cells or stop them from growing and spreading because we're just binding to those cells and we're interfering with their ability to reproduce. There's many types of monoclonal antibodies that have been developed for various purposes, and some of them, again, they mark the cancer cells. And then what happens once they're marked? The immune system can recognize them and can kill them more effectively. So we're not just keeping them from reproducing, we're actually causing them to be taken care of by the body's own immune system. We're sensitizing the immune system for a better response. And the antibodies can be used to treat diseases themselves by the detection of the presence of specific antigens and blood or tissue samples. They can be used to deliver drugs or radiation to specific sites in the body. So you're basically tagging or targeting the specific cells you're looking to be effective for. Once again, all that can be Googled and looked at for all of you in the general public that are listening, all the ham radio operators that are listening, anybody that sees our YouTube video. Please do follow up. We're just putting the basis here for for you to inquire in more detail. I think many of you will identify and be thankful for these therapies. You may have patients in your family that have had these type of treatments. And if not, you'll be seeing more and more therapies that use these as the baseline for design and treatment. And as Munir talked about multiple sclerosis being the autoimmune disease where the autoreactive T cells cross the blood-brain barrier and attack the myelin sheath, leading to a cascade of inflammation that results in demyelinization, and you get subsequent degeneration. And unpredictable episodes of neurological disability in young adults are followed by gradual accumulation of deficits over time because the disease, as he mentioned, can switch from inflammatory to degenerative secondary progressive phases of the disease. The monoclonal antibodies, and Munir also talked about having heard first about this 30 years ago, that started as experimental treatments in the 1980s. And the advantage is that high specificity for the target. But there are disadvantages. They usually require intravenous administration and often associated with infusion reactions. As large foreign proteins, they are immunogenic. So that personalized medicine, that therapeutic index we're talking about, becomes even more important. This information was taken from an article called Monoclonal Antibodies and Multiple Sclerosis Treatment, Current and Future Steps. And you can search for that one online. It was in the Advanced Neurological Discord 2009, Therapeutic Advances in Neurological Disorders Journal. So look that up for further information. Just go ahead and do a Google search. And there, thank you for bringing that to our attention and expressing your thankfulness for that aspect of therapy. As we talk about Alzheimer's disease, there are also science-based articles discussing that multifactorial progressive neurodegenerative disorder that has a poor prognosis, and thus novel therapies are needed for Alzheimer's disease because we have a growing population of elderly patients or asymptomatic individuals who are at risk. And in a particular article here, Novel Strategies for Alzheimer's Disease Treatment, an overview of anti-amyloid beta monoclonal antibodies, as Munir was talking about the amyloid. This article goes into some of the science behind it. You can Google that one as well. The author's last name was Rygiel, Rygiel, and you can find that through searching through that article. You can also find it through PubMed or just you can do an NIH search for those names that should come up for you. And the review that was in this article was based on Medline database search for trials on passive anti-Alzheimer's disease immunotherapy, and they looked at through the time frame of 2012 to 2015.
Like within half an hour.
The goal here was to review the results of the clinical trials in the monoclonal antibodies against amyloid beta used for the treatment to address some of the current challenges and strategies to prevent AD. Munir, would you like to make some additional comments about that? If you do, go ahead and do so. N3PQ, Whiskey, Bravo 5 Delta.
Yes, this is N3PQ. Thank you, Jay. Yeah, am I allowed to mention like trade names and company names, or is that not okay?
It would be okay to mention trade names. Again, we're not giving any diagnosis. We're not selling any products here. This is just a discussion amongst amateur radio operators.
Okay.
Passion for healthcare.
Okay, I'll tell you why. Only because they are so much easier to pronounce than the generic names, to be honest with you. So anyway, there were Leqembi. That's the one I was gonna mention. Thank you very much. You're reading my mind, Jay. So there's Leqembi, and there's the new one from another company, and it's adalimumab. I believe the brand name is Kinsula or Kisula, something like that, Kisula. They are both about equally effective. The differences are that Leqembi takes longer to clear the amyloid plaques, and you have to give it for a longer time. As a matter of fact, there's no specific time when you can stop it. On the other hand, it has fewer side effects. The other one, adalimumab, which I believe is Kinsula, it's given over a matter of about, if I'm not mistaken, a year and a half. Don't quote me on that, but a matter of months. And then after that, 18 months, you can stop it, and it clears the amyloid faster, but more side effects, somewhat more side effects. As far as efficacy, I mean, they are comparable. Maybe the one that works faster is more efficacious, but overall, they are in the same ballpark, more or less. And again, talking about therapeutic index, yeah, that's for the cancer one. That's Herceptin, another paradigm shift in cancer. Again, as we get better and better at personalized medicine, and the therapeutic index will improve. The benefit to risk ratio will definitely improve from just a year. These two medications are improvement over the one that first came out, the one that opened and there's one in the pipeline. There's actually quite a few in the pipeline. I take that back. There's one that's closer in the pipeline, but there's quite a few in the pipeline, other MABs for Alzheimer. And I expect they will fine-tune their action and improve the therapeutic index further. That's my expectation. This is N3PQ. Over back to you.
Okay, thank you, N3PQ. This is Whiskey Bravo 5 Delta for identification, medical amateur radio counselor, grand rounds on the internet. Thank you for everyone's allowing us to declare frequency. We're still going to be having this net for a little bit longer. It's interesting hearing all these in real time. The discussion that started 30 years ago in development that's still ongoing and will continue to be ongoing. Think of all the changes in medical research in the last 30 years. You can see why we're able to be more specific now with our therapies, and it will become more and more so, again, as we understand the genome, and it's more effective and less expensive to process that information with greater computing power and more knowledge even between species. Now, Linda, you're still with us, K5BQK. I know you're thankful for the medications that you mentioned. That we have a brand name here for the medication that you had taken. And of course, it mentions the information on their website. It's called Enhertu, ENHERTU. If you want to Google that, guys, and see where it's effective and how it's effective and all the detail that they have there. Linda, would you like to take the questions? Let's see if anyone has questions for you. This is Whiskey Bravo 5 Delta. Any questions about breast cancer related treatments, these treatments that are used? And also for Linda, you might ask her question, do they add something else to just the antibody that makes these particular medications more effective? I'll take a list right now. Make your call to Whiskey Bravo 5 Delta. Yeah, I hope everyone on the air here is finding this discussion to be interesting. All individuals, all hams can ask questions. You might have family members that have had breast cancer, or had Alzheimer's, so common, Alzheimer's, and as well as MS and myasthenia gravis. So, Linda, if you're still with us, there's particular information from the company that manufactures the drug mentioned that there's kind of an inhibitor conjugate combined with it. So it would seem to me that it wasn't just the antibody, but there's other components that make the antibody more effective. Do you have any comment about that? KE5BQK, Whiskey Bravo 5 Delta. I know Linda was in transit. She was hanging on a little later for us before she hit the road here. So he has other activities today. But going through that information, we can all look online and see more details about that. You know, and having these discussions or having these interactive roundtable discussions on the air, having a Zoom component to it, we find that every time we bring up a subject, it brings up more questions than even the answers. It just it stimulates the conversation. We do have a journal called The Ether that comes out every 3 months, and you'll see the discussion furthered as well as on additional grand rounds. And they were always taking suggestions for subject matter. So please don't be shy about writing in using our QRZ email contacts, either AA4FL directly here for my QRZ information or for the organization itself. Now, CHEP N5 RTF is with us, and CHEP, I'm going to turn the microphone over to you here. Maybe you can come in. I'll turn it over to you. Yes, I'll let you unmute. And if you talk about cataract surgery and the personal impact that it's had on your life, and as a psychiatrist, CHEP, if you would also mention the behavioral aspects, the improvements in one's mental health that would occur from having full vision, similar to when we talked about having full hearing before. N5RTF, Whiskey Bravo 5 Delta, go ahead. Okay, we have a pause for a minute. I think we're having a little bit of a technical aspect, technical difficulty. We're looking for the audio feed here for my station as me being the net control operator. N5RTF, are you able to transmit and discuss some of that today? Go ahead.
There we go. Yeah, I'm using a tablet, and the buttons are tiny, so my finger was too big. Yeah, I just wanted to say that about 6 years ago, I started losing my eyesight. At first, I was having halos and having trouble driving at night, and I finally got to the point where I couldn't hardly see at all out of one eye, and the other one was fading. Went to my normal optometrist that I had been going to for years, and he said it was just rapidly advancing cataracts, and recommended that I go to a surgeon for an evaluation. And he said, "Well, let's go ahead and do these." And they do them 1 month apart. So you don't want to have both eyes out at the same time, or if something goes wrong, you want to revise what you do to the other one. But we had previously on Marco a presentation by Bud N5AM in Lafayette, and he had discussed cataract surgery, including lens options. And when I went for my evaluation, I knew exactly what to ask for and what questions to ask and what to prepare for. And it made my experience a whole lot better. But that's probably the best thing I've ever done. I spent my whole life nearsighted. And suddenly I woke up in the morning and I could see, and not even the other thing people who have cataract surgery will tell you is the colors are just amazing. It's like the whole world is lit up in neon, and that doesn't go away. I mean, that's still to this day, all the colors are absolutely bright. Before the gradual development of a cataract is not noticeable, but everything turns shades of yellow and orange. Looks like those old Dutch masters paintings, and then suddenly you can see color again, and it's just dramatic. Without that surgery, I would be blind. And I just, I'm grateful for it every single day in 5RTF.
Okay, and 5RTF, thank you, Chip. I'm sure many of you are familiar with cataract surgery because of the age group of amateur radio operators. You probably have cataracts that are getting ripe for removal. Perhaps some of you haven't had removed and you're wondering why. Maybe you're seeing glare at night, or you're seeing letters don't seem clear at times and don't realize the reason why. But hopefully you're going to your ophthalmologist. We do have other ophthalmologists here with us today. Ophthalmol, of course, Chip is as a psychiatrist. There's a component to the psychiatry and behavior and well-being. But Barry, WB1FFI, do you have any comments that you'd like to make about cataract surgery from an explanation and a technical standpoint? Go ahead.
From the time I started in ophthalmology, I used to maybe one or two. It's huge, a tremendous improvement and evolution of the safety, the technique of cataract surgery. That's just miraculous. We just, the young residents that are training today, hopefully have a chance to study the history of cataract surgery evolved from the original intraocular lenses that Ridley discovered canopies of what got down in World War II. Experienced these orthos encapsulate glasses that was in their eyes was an they couldn't cause any problems. So the whole industry light technology evolved over the years. Originally, if you were fortunate to have a safe cataract operation, you were usually patient, which means that you know it's possible lens, and you have the techniques called Coca-Cola glasses, because you know Coca-Cola bottles with those tips. There was plus 15 language, this focus. They were totally out of focus without them. And implant started, that was a big improvement. And then of course now we have the flexible, bendable materials, acrylic, silicone, multifocal capabilities, what we call corner capabilities, correcting astigmatism and so forth. So it's the whole package in and of itself. M5AM has done a beautiful reputation of this a number of years ago. And it's probably deserving of another discussion for another day. But I'm glad that Chip had the benefit of the modern technology. We all develop cataract. It's not a disease per se. And it's important to explain to patients if they hear the word cataract and they think something, their first thing is, I'm not going to go blind. And of course, the answer is no. It is a suitable condition. We can learn it safely. But for the most part, useless. What's a 20 to 30 minute operation we will send it. So if anybody has any questions, if we're running into the second hour here, but this is a topic in and of itself worthy of discussion. I'll send it back to WB5B.
Okay, thank you. WB1FFI, Whiskey Bravo 5 Delta. Do we have any questions of Barry? I'll make a list. Go ahead and ask your questions. Okay, thank you, Barry. Barry, we're talking about thankfulness, and we appreciate the ability to have cataract surgery done, of course, but let's not forget that not only is it the surgery itself, it's a whole staff of individuals that are responsible for developing the surgery. As you mentioned, the materials, the intraocular lenses. We have appreciation for the ophthalmologists that do the procedure, having the surgical microscopes available to do the surgery, the local anesthetics that are used. And these are all subtopics that take place in completing a procedure. I mean, we've got lasers, we've got day surgery centers. There's so many different technologies and medical staffs associated with a particular treatment that we really need to be thankful for everyone. So you're going to get that improved vision all times of day, better quality of life, which will expand one's lifestyle, protected eye health, driving safety. Think about the driving safety when you can see better. When that cataract gets bad enough, that needs to be treated. Because as Barry mentioned, they happen. You live long enough, a lot of you are gonna get cataracts that are clinically significant. You have an improvement in mild Alzheimer's symptoms, possibly contributing towards prevention of Alzheimer's. And think about the falls that occur when you can't see well. What about the head injuries? So you're also preventing injuries. There's a lot of health benefits here with cataract surgery. We're certainly appreciative of all wells. Are there any personal stories from our members? You'd like us to tell about your experiences with having cataract surgery and how it helped you? I'll take a list. Go ahead. Okay, I don't have anybody verbalizing that they'd like to tell a personal story about cataract surgery, but I'm sure you've seen members in your own families that are parents or uncles and aunts or brothers and sisters that have had it and have had improvements in some of the symptoms we talked about. I know we're getting a little long here today. There's lots of other medical advances we could be thankful for, things like general anesthesia, antibiotics, MRIs, artificial joints, dental implants, interventional radiology, the computer-assisted design and manufacturing technology. What about electronic health records, birth control? And I'm sure there's many other prominent advances that you would like to contribute to. And we'll build on this in a future presentation. We're getting a little bit long here today, but we'd love to have you write in. Again, look for that email address on the QRZ page for either WB5D or AA4FL. And please write in, or if you're a member of Marco, write in on the Google group and tell us the other prominent advances, because Thanksgiving is coming up on Thursday. We still have 4 days to be thankful, and we can be thankful as a group on our reflector. For me, I'm most thankful for the medical staff and technology, because they've allowed me to have my medical challenges met. I've had kidney cancer twice, and I've had thyroid pathology, dental implant needs, and I'm also thankful just for Marco and Healthcare Hands. It's an everyday activity that facilitates my well-being and happiness. It allows me to connect my profession to my hobby, and that's why we're here on this net, and share the enjoyment with other like-minded individuals who have a passion for amateur radio and health-related subject. Now, we do have that publication called The Ether, and a lot of my favorite medical advances have already been covered in the pages of The Ether. And there's going to be plenty more current and future advances, things that are ongoing: stem cell therapies, genetic personalization of therapies, CRISPR, gene editing technologies. Look at what's happening with expanding weight loss drug options now, the new pharmacological therapeutics for Alzheimer's we're talking about. What about AI-aided detection? An example would be early detection for sepsis. They have a targeted real-time early warning system for sepsis aided by AI. The quicker you catch it, the better the outcomes. What about artificial glove? What about blood? What about lab-grown organs? What about bionic eyes? I mean, there's all kinds of aspects that you feel could be future advances you might want to know about. We can do further sessions on the Grand Rounds of the Internet, but we need to hear from you. So please write in and tell us. And again, the Ether publication, if you're a Marco member, you're going to have access to all these publications. We did one in October of 2021 that was just on technology and medicine. We went into a lot of the detail, interventional radiology, molecular epidemiology. And we talked about certain procedures like percutaneous cryoablation from the interventional radiologists, on and on and on, and the ways that they help. In addition, we talked about genomics and medicine. We talked extensively, of course, about COVID and the implications? What about robots in medicine? Radiation therapy technologies, things like gamma knives and cyber knives. There's all types of ongoing improvements. Now we have computer-aided and AI-aided surgeries and devices. So we can expect a lot more advances in the future. And we had even an edition in February of 2022 that was about the education, science, and technology and dentistry, and showed some of the parallel developments in the dental field. And if you'd like to write in with any additional veterinary medicine, pharmacology, and have that included in the ether, please contact me. But thank you very much. Feel free to contact us with feedback or input for further discussions. My email address, you know how to find. You can also visit us at marcoltd.org, marco-ltd.org, or healthcarehams.org. We do have websites you can contact us on. That being said, we're going to get ready to bring the net to a close, but if we have any additional questions or comments, this is Whiskey Bravo 5 Delta, Medical Amateur Radio Council, Grand Rounds on the Internet. Make your call with your question or comment now. Have a wonderful Thanksgiving, everyone. No additional questions or comments heard. This was a very active discussion, an ongoing discussion that's going to occur on all levels of Marco, and we look forward to your continue being part of the organization and our new friends, and being here for all amateur radio operators who can monitor our net. And we also need to be thankful for Chip on marcoaudio.net, who does a live web stream, and these will be also recorded, the full net and audio version on our archives, marcoaudio.net. 7-3, everyone. I'm going to bring the net to a close and return the frequencies to the general amateur radio use. Whiskey Bravo 5 Delta 7-3.
Great.